Well, good afternoon out there in SADS Facebook Live land. Mike Ackerman, genetic cardiologist at Mayo Clinic, coming to you here on December 18th from Lutsen, Minnesota. Just came off the mountain from skiing with my son and really excited to spend the next 40 minutes with you. So wherever you are across the globe, thanks for joining us for the 43rd Sudden Arrhythmia Death Syndrome, SADS, Foundation's Facebook Live program. We've been doing this since probably February or March, and it's great to be with you. And even when the pandemic ends, and it will be over someday, we will continue to do this with you and join you. So on behalf of Alice, Laura, the CEO of the SADS Foundation, thank you for joining us. This is our last one of 2020. So happy end of the year to all of you. We still are in the midst of the COVID pandemic. I'll give you some reminders. Remember, wear your mask. That's what I was wearing just about 30 minutes ago before we got off of the mountain. So mask up, put them on, wash your hands, stay social distance. Let's do all the right things until we're vaccinated and beyond. I just looked up, we are at 75 million cases worldwide, 17 million in the United States. We probably, by the time this Facebook Live session is over, we will have reached 312,000 deaths in the United States. We're still averaging just under 3,000 deaths every day. So we have a lot of work to do. There is good news, obviously, right? The vaccination has started. We have the Pfizer vaccine approved last week. Earlier this week, the second vaccine from Moderna or Mode RNA, their vaccine received unanimous FDA approval. We started the vaccination program at Mayo Clinic yesterday on my wife and my anniversary, with the first person receiving it on our campus was a nurse for our emergency department. So she was the first person to receive the vaccine, and that's underway. I will likely get mine in mid-January, so I need to stay corona-free for another 30 days. And earlier today, we had live the Vice President of the United States, his wife, and the United States Surgeon General all receive the vaccine for SARS-CoV-2 this morning. So it's happening in the United States. It's happening across the globe. The vaccine, now 2 of them are underway, and the vaccination programs are being rolled out. Well, that's the COVID-19 update. But now I want to do our end of the year celebration in a fun way and bring the Vice President of the Board of the SADS Foundation and my dear friend, Dr. Susan Etheridge, is joining me. So Erin's going to do her magic and bring Susan on, and drum roll, and there she is. And Susan and I, like before, we did about 6 months ago, are going to take the top 10 most asked questions or most posed questions to the SADS Foundation and go through them Dave Letterman style. And we drew straws. Susan, I think you drew evens and I drew odds. Is that right?
Right.
Well, and this is our final one with all of you out there in 2020. And so for those of you joining us, thanks for joining us today. And you can feel free to pose questions on the sideboard. We'll grab those and I will take them when I'm with you on January 8th. We have some really exciting programs coming up for 2021. But we have now about 3.5 minutes per question. And Susan and I have not seen them. So this is going to be fun for us to react in real time. And so Erin, bring up the first question. Question number 10, posed to the SADS Foundation this year, the 10th most asked question. Susan, my daughter with LQTS is pregnant. Now, that's not my daughter. I'm just reading this. My daughter's 17 years old. She's not pregnant. My daughter with long QT syndrome is pregnant with her first child. What does she need to know?
That is an excellent question, and one I'm glad was asked. Actually, glad she knows she has long QT syndrome before she is delivering her baby. I think most of the data would suggest that women with long QT syndrome do very well during the pregnancy. It is, it's a time they're very stable, and they should continue their beta blocker therapy. I think that's very important unless there's a reason their cardiologist feels it should be changed. And then certain patients with long QT syndrome struggle in the postpartum period. So I'll typically watch my long QT syndrome patients closer for the first 9 months after the delivery of their child. The other thing is there are some fetal manifestations of long QT syndrome. And so it is, again, important that the mother knows she has it so the fetus can be watched. The most common is that the fetal heart rate is just slightly slower. And it's important that the obstetricians know that the fetus has a 50-50 chance of having long QT syndrome, because that might explain the slowish heart rate. And they don't go getting worried that the fetus is under distress. There's also arrhythmias that can occur, but they're often quite rare. But again, it's important the obstetrician knows what's going on and what to look for. Mike, anything I missed?
No, I think you did great. I think especially right, Susan, is to make sure that the obstetrician doesn't do anything without consulting her long QT specialist, like choosing to stop the beta blocker without notifying you first, so that we would be changing their mind about that. You and I see that all too often, I'm afraid.
And there are some that might be used in the in pregnancy that are something that the long QT specialist should at least know are being used and watch the mom closely, like Zofran or Pitocin. Try to avoid if you can, but certainly incorporate our thoughts before just giving those medicines.
I think one thing I would add to that too, Susan, don't you think? I don't view this daughter. First, congratulations to this person asking the question for their first grandchild. I can relate to that. I don't view your daughter's pregnancy, as a high-risk pregnancy.
Neither do I.
I know there's debate out there, but I don't like labeling your daughter as a high-risk pregnancy. And I think, Susan, you share that view as well, don't you?
I do.
I think we've hurt young women by calling them, and then all the things that they're doing during the pregnancy, and snatching the baby away in the newborn nursery right away, and making it not near as special of a moment as what it should be. So congratulations. And if your daughter is seeing a good cardiologist and a good obstetrician, your daughter's in good hands. And Aaron out there, I think with pause, Aaron. Oh.
All right. You can all hear me?
Yes.
What are the symptoms of progression of ARVC, Dr. Ackerman?
Well, that's a good question. So ARVC, for those who may not be familiar, is arrhythmogenic right ventricular cardiomyopathy. That's undergone several name changes. Some of you might know your disease as ARVD, or arrhythmogenic right ventricular dysplasia. Sort of now the more collective umbrella of this kind of cardiomyopathy is ACM, or arrhythmogenic cardiomyopathy, of which the most known or most common one is the specific one of ARVC. And I think we would be telling people that there's two different lines of progression of the disease. One is electrical chaos, and that's not as much progression as that potentially could be uncertain or random, meaning will the ARVC muscle, will it suddenly electrically go out of control into a dangerous rhythm, which could make you suddenly faint, suddenly collapse, and suddenly need a resuscitation. So part of ARVC can progress down an electrical pathway of chaos. But the other one, I think most often when we talk of progression, we talk about the heart muscle getting weaker and weaker and progressing in terms of signs of pump dysfunction, where the pump is failing, and you hear about the term heart failure. And so some of the symptoms that the pump is not working as well and is failing are things like becoming more out of shape, getting short of breath, shortness of breath with activity. You used to be able to do the flight of stairs just fine, but now you're particularly winded doing the stairs. So there can be signs of failure or progression with the right pump getting weaker, some distension or congestion in your neck or in your abdomen, a swelling in your lower extremities. So those would be symptoms that the ARVC heart as a pump is failing, and would be symptoms of progression. Any symptom that you've encountered, Susan, that you would add to that list?
Occasionally the pain as the disease is progressing.
Yeah. And I think sometimes we would tell them new chest pain, new palpitations, the new change, because the ARVC heart can go in so-called flares, where there might be indicators of increased failing or progression taking place. Well, Aaron teed up for number 8 for me to read to Susan. Oh, good question. Will acquired long QT syndrome go away, or will I always have it? So Susan, maybe a little bit about the difference between congenital long QT syndrome and acquired QT prolongation, which you and I probably like to refer to it that way rather than necessarily calling it acquired long QT syndrome, because it confuses people.
Yes. Acquired means that you've gotten it. You weren't necessarily born with it, or probably don't have a known genetic issue that causes it. And it can happen with medications. It can happen with electrolyte imbalances. It can happen with diet changes, significant diet changes. And I think it has a great chance of going away. In fact, some of the worst or longest QT intervals I've ever seen have been actually in the acquired population, very low potassium or exposure to multiple agents that can lengthen the QT interval. I think as long as you never encounter those situations again, or you are try to protect yourself from those situations again, then you should not have further issues with QT prolongation. I think that as time goes on, we may uncover subtle genetic variation that make me more likely to respond to a certain medication with QT prolongation compared to Michael, for instance. But at present, I think the data would still suggest that acquired can go away once the insult that caused it is eliminated.
That's great. I think a great example is somebody who goes into the emergency department with low body potassium or hypokalemia, and its potassium is 2.8, and the QT interval may be very long. And then when the potassium is normalized and the illness or whatever brought it about, the QT goes back to completely normal. And so that gets called acquired QT prolongation, for which is corrected and resolves after the situation resolves. Before we do number 7, I'll back up. Anne posed a follow-up question about, I think maybe she didn't hear us about that stomach symptom on ARVC progression. And I think you were referring to right pump failure and new stomach pain, or more bloating or abdominal distension. Is that what you were getting at, Susan?
I don't think we said it. I said chest.
Oh, chest pain. Okay. So I think she heard stomach.
Although it's actually not a bad point, because kids sometimes with heart failure will have more GI complaints. It's unlikely for a child with ARVC to be developing heart failure, but sometimes heart failure is manifest in children with abdominal complaints, nausea, vomiting, poor feeling.
Yeah, yeah. Great.
All right. Can people with CPVT live a normal lifespans with medication and lifestyle modifications? Fantastic question.
Yeah, great question. The answer really is not can, but they must, they should, they will. So CPVT, for those who may be new, is catecholaminergic polymorphic ventricular tachycardia. 2/3 of all CPVT is accounted for by mutations, variants in one gene, RYR2. So you may know that you have RYR2 mediated CPVT, which we would call CPVT number 1. And if we know you have CPVT and we've dialed in our CPVT treatment program, which almost always consists of a beta blocker, mostly nadalol, often dual drug therapy, nadalol, beta blocker, and flecainide, sometimes triple therapy, nadalol, flecainide, and the left cardiac sympathetic denervation, and usually with double therapy or triple therapy, for which Susan and I try really, really hard not to use an implantable defibrillator in CPVT. But with you on dual therapy or triple therapy, life should be long lived. In other words, I would expect you to die from something else and not your CPVT. And not that you would just die from something else, but while you're living, you would be living large with your CPVT. And sometimes living large includes staying an athlete. If you were an athlete before, that's a little bit of debate, but we certainly have plenty of athletes with CPVT, and I even have a couple of professional athletes with CPVT. So the point being, life should be long. You should die from something other than your CPVT. And while you're living in your childhood, adolescence, young adulthood, and older adulthood, like my adulthood, you should be living and experiencing an abundant life.
I have a kind of a follow-up question, Mike. You see more older people than I do, more older CPVT patients. Do you find that the burden of symptoms is actually when kids or children or adolescents and things sort of quiet down as they get older?
I do. I think if the CPVT heart hasn't caused a faint seizure or worse, by age 40, and really by age 20, 25, it's really unlikely that it's going to spontaneously erupt after that. Now, having said that, I have a handful of CPVT individuals where their first event included cardiac arrest happened in their 50s. So it's never a never on any boundary end, but really the vast majority of events, I think, are happening in childhood, even before puberty. So it's kind of it'd be interesting to see the exact breakdown. Do most happen before puberty or after puberty? I think that might be a close tie on the before versus after puberty. Do you know which side would you have fallen on if you were betting before puberty or after puberty in your own CPVT program, Susan?
I would have before and right at puberty.
Yeah. I think that would be so. And Aaron, tee up number 6. That was a great question, by the way. So Susan, this person's asking that her son was diagnosed with Brugada type 1 after his brother died, and he had a procainamide challenge. His doctor, following guidelines, said no ICD, but my doctor thinks he needs one. What do we do?
Well, that's an important question. If I am interpreting this right, you have Brugada, your son has Brugada 1, meaning he has an ECG that is, well, I don't know the answer to that. So I think it depends on whether his ECG at rest, not with a provoked challenge, is demonstrating the Brugada pattern. If that's the case, then I think most people would think an ICD. Mike, thoughts? If you have a spontaneous Brugada pattern and a known Brugada syndrome, that would be a higher risk group.
It would. I think this is a really good question, and it's a tough one, and I agree. But I think, the important thing for your family, I mean, obviously you've had the incredible tragedy of having one son die already, thinking that your other living son now needs a defibrillator because of the death of his brother, your son. And there I would say no. The family history, tragic as it is an emotional risk factor, but it's not an evidence-based one for your living son to get the defibrillator. So there needs to be something about the Brugada in your living son. And so if he's never ever had a symptom and all he has is the Brugada pattern, even spontaneously, he would not be getting a defibrillator yet. Now, would we think about, depending on his age, doing an EP study to see whether we could easily induce a danger rhythm or not? Some programs would, some programs would not. Would your son need all of the preventative measures? Absolutely. If your son had a spontaneous pattern, would he be started on quinidine prophylactically? Some programs would. And so this is your scenario is such a good question out there, for which I don't think there is the absolute only singular way of navigating the next steps.
I think there are other concerns. We sometimes Brugada. One is the fever, the aggressive temperature control, and that there are certain things, certain drugs that can make Brugada worse. And some of those are unfortunately controlled substances, you know, or street drugs. And important that teenagers know that marijuana, cocaine, especially the combination, can cause trouble. And what do you think, Mike, in this patient, if you don't go forward with an ICD, about having an AED in the home?
Yeah, again, I think it kind of depends on what's the age of this son. In general, I do like the idea of the automatic external defibrillator, the AED, as part of family safety gear for our pre-adult patients. We have tended not to have an AED as part of safety gear for our adults with a variety of their congenital arrhythmia syndromes or channelopathies, just because I think the logic breaks down with who's there with the adult and so forth. But if he is a 12-year-old, I think it's a decent piece of safety gear to have. That's for that person who asked that question out there. You know, I know Susan and I would be more than happy to talk more with that family, even do a video consult for that family if they wanted a second opinion, because that question that was posed is such a good one and not a straightforward one at all, where the answer isn't such an immediate snap of a finger, only one way of doing it kind of answer.
All right. My 7-year-old daughter has spells that the doctor says are low blood sugar. She has long QT syndrome and is taking nadalol. Is this normal? What an excellent question.
Yeah, so the whole issue of low blood sugar on beta blocker therapy and causing spells, I think it depends on whether it's been documented. So first of all, hypoglycemia on nadalol or propranolol beta blocker therapy in long QT does occur. It's extraordinarily uncommon in adults. It's extraordinarily uncommon in teenagers. Among those most vulnerable, it's really the toddler to the 6-year-old. So the 7-year-old, that's a little bit old already for this. Now, if she's a really petite 7-year-old, maybe a possibility. But really, this hypoglycemia thing occurs in that window of, let's say, newborn, but even that first year of life, there seems to be protection from it. And then it's kind of age 1 to 5. Let's put the boundaries there, which is really interesting because beta blocker, Dr. Etheridge used oodles of beta blocker on not long QT small kids with SVTs and basically never, ever, ever sees hypoglycemia. So why do long QT kiddos can see hypoglycemia? Well, it turns out that the LQT1 individual and the LQT2 individual, that exact same potassium channel that's defective in the heart, does do a little bit of insulin secretion regulation in the pancreas. And they have otherwise a very subclinical insulin glucose control balance issue, which almost never rears its head. But where it rears its head, and it rears its head in that age range, 1 to 5, at about a 5% frequency. So it's not very common. But the setting in which it does is 3-year-old feeling a little bit under the weather with some crud, wasn't taking much nutrition at the evening, then took their nighttime nadalol dose on not much nutrition, and then by morning, they woke up hypoglycemic and sometimes even with hypoglycemic seizures. So not trivial low blood sugar issues. And ever since we've been aware of this and published this now a few years ago, we've told our families, make sure they've taken their caloric intake at night. If they haven't because they're under the weather, I'd rather have them skip that nighttime dose than take the nighttime nadalol while fasting or in a relative fasting state. And since then, we've almost never have seen this hypoglycemia thing. So it may be true for your daughter that the spells is sugar related. I'd like to see it documented rather than just blaming it on nadalol blood sugar reaction, because your daughter's a little bit on the old side for this episode. Things that you've seen before we do number 4, we're just past the halfway part. Anything you would add on that, Susan?
I think exactly what it is. Toddlers. And some of that is that toddlers just decide today they're not going to eat, and there's not a whole lot you can do about it. And we have on occasion given glucometers to families to try to document, and occasionally we have documented it. The other thing I think is if we catch it early, like sometimes there'll be some subtle changes in how the toddler is acting. Obviously, this isn't anything we can do at night, but they'll be just a little mean. And I always tell the families, if he's mean and you can't figure out why, just feed him. And even if that's like liquid something with sugar in it.
Yeah. They consulted you for that Snickers commercial, right? That hangry.
Maybe that's where I got it.
Okay, Aaron, number 4, I'm delivering. Oh, good one. Dr. Etheridge, what do I do for my kids when I have Brugada?
That's an excellent question. They should be seen. They should be tested. Hopefully there's a genetic target to test for. About a quarter of people with Brugada syndrome have a mutation that can be tested for in the sodium channel. And if they are negative and you have that mutation and they don't, then they can be discharged from clinic. If they do have that mutation, then they need to be followed by a specialist who understands Brugada syndrome in children. And then, but if you're gene negative, if you're one of the 75% where there's no gene target, then the children need to be followed at least with electrocardiograms. And I try very hard to give them a little prescription so that when they have a fever, they can go to the emergency room or clinic and get an EKG with a fever, so that sometimes can unmask what might not be there at rest. As far as doing provocative challenges, you can weigh in on this, Mike, too. I used to do a lot more procainamide challenges than I do these days. I have just been unimpressed by the ability to pick up a Brugada change with procainamide compared to with what you see published from the folks in Europe with ashmolein or with IV flecainide. So I haven't run to do that test. I have done it a couple of times when I really needed to know. But I'm thinking that the fever test may be a better test than the procainamide challenge.
Yeah, agree completely.
Number 3, Michael, I had genetic testing done at Vanderbilt in 2013 for long QT. It looks like nothing was found. Have there been more genes identified since then? And should I get genetic testing done again? Oh, good question. And it's a good person to be asking the good question too.
Yeah, I think first of all, anybody out there who has a negative genetic test done in the research era, meaning it came from a research laboratory like mine, where we said nothing was found or you never heard. Vanderbilt 2013 probably was not doing it as a research test. They would have been using a commercial company of some sort then, because long QT became commercially available genetic testing, that is, in about 2004. So if it was negative in 2013 and the long QT profile, the clinical diagnosis is obvious, like obvious, I would actually redo it now 7 years later in 2020. So honestly, whether it was a 2010 and before research test that was negative, I would redo it. If it was a 2015 and before clinical test, I would redo it, because since then there's probably been at least 5, 6, 7 new LQTS genes published. All of them are rare, but one of the collection that would have been added since then have been mutations in one of the 3 calmodulin genes, for which Susan and I have published on the so-called calmodulinopathies. And I think, Susan, you just recently wrote a review on calmodulin-mediated long QT. And so you do not want to miss being that version of long QT. And also tried and knockout syndrome has been published since. So each one of these are sort of 1% add-ons, but they're very important 1% add-ons, especially if the person who has long QT is a 5-year-old or under who had aborted cardiac arrest, so big deal long QT syndrome, and you are told you're gene negative as of 2013. Even though it's a small contribution, there's a good chance that that 5-year-old with the cardiac arrest who's gene negative could in fact be calmodulin long QT or one of the newer genes. So bottom line, I would redo the genetic test in 2020. If that test was negative, comes back negative, I would then hook up to a research program like ours or others and do a discovery for your family's long QT cause by doing whole genome sequencing of all of you, the one who has long QT, and both of the parents. Okay, number 2, the second most asked question. Oh, this is a good one, Dr. Etheridge. My daughter has CPVT. What about an ICD for her? When, why would she get an ICD?
This is an excellent question. I, like most of us children with CPVT, we're trying very, very hard to avoid ICDs in this population because they can be problematic, and because there's other very good therapies for CPVT. Just as Michael said earlier, nadalol therapy, all patients are likely to be on nadalol. The addition of flecainide to that has resulted in a significant decrease in symptom burden. And then the left cardiac sympathetic denervation has also been very helpful in this population. In a symptomatic CPVT patient, meaning somebody who faints or has had, even somebody who's had a cardiac arrest, I will use triple therapy. Very hard trying to avoid an ICD. I have older patients where we didn't really know there wasn't triple therapy. It was before flecainide and before the common use of a sympathetic denervation, and they have had ICDs, and they're problematic. They give children shocks while they're awake. That's an adrenaline surge because it's painful. And then they can have what's called a storm, where they have an arrhythmia, get another shock, have more arrhythmia, get another shock. So trying very hard to avoid an ICD in this population for the life of the child, if at all possible.
That's great.
All right, I get to read the number 1 asked question. I was diagnosed with epilepsy for 30 years. After the birth of my son, I had so many seizures, which we now know was long QT type 2. At diagnosis, the doctor said Dilantin was somehow helping me.
Oh, that's a good one. I would say our families out there in our SADS Foundation community for 2020 and the years before, you guys are amazing. You asked some great questions. A couple things here, and I'm looking at our time because I want Dr. Etheridge to give her final 2-3 minutes of the year, and then I'll give mine. But I think this link between seizures and long QT is so well known now, And it frustrates Dr. Etheridge and me beyond belief, the number of families who have been misdiagnosed many years, sometimes decades, as being epileptic before the correct diagnosis of long QT syndrome is rendered. Sometimes where casualties and tragedies have happened in the family structure in the name of epilepsy before people thought to look at the organs south of the brain, the heart. And it turns out that LQT2 families are far more likely to have been labeled as having seizures or epilepsy than LQT1 families. So there's something about the connection where it could mean that LQT2 people, when their heart does this, their brain gets electrically ticked off quicker and shows seizure activity. Or it could be that the LQT2 potassium channel, which resides in the heart, is also in the brain. And could there be a neuronal potassium dysfunction phenotype called epilepsy? And I think the correct answer is yes and yes, that both are possible. And so it really comes down to being really careful about making an accurate diagnosis. Now, the doctor's observation about Dilantin, kind of interesting, because the doctor is probably right, because Dilantin is a sodium channel blocker. Dilantin happens to have sodium channel blocking properties similar to mixilotine. What is the newest medicine that we've been using now, probably for the last year, where we just recently published our early experience in LQT2, but mixilotine. So it's not as if any of us long QT specialists are going to be quick to start using Dilantin again in long QT patients. I don't think we'll need it. But I think his or her, that doctor's observation, he or she may have been spot on about the notion of Dilantin helping your situation. Well, 10 great questions, and we have 3 minutes, Dr. Etheridge, to the top of the hour. And before I have Aaron take you away, why don't I give you the stage to give your thoughts, anything you want to share with the SADS Foundation Facebook Live world about your review of 2020 and what you're looking forward to in 2021 before I let you go. And great seeing you, Susan, and thanks for joining me.
Thank you. So 2020, a challenge, but there have been things that have come about. I think that conferences such as this have kept us connected and maybe even improved connectivity, because it's not like I get to sit and talk 3 times a year, 4 times a year to this group of patients from all over the world. And I've gotten to do that on my 3 sessions with Dr. Ackerman. And I've gotten to watch Dr. Ackerman interview a bunch of my other friends from the SADS Foundation. So there have been actual positive things that have come about. I appreciate everybody's resilience and continue to be vigilant in this last couple of months, because it will end. We will be done with this thing, this virus, by summer, and we just have to stay healthy till then. Thank you.
Great, and thanks so much. Susan, you are an amazing colleague, a dear friend, and I wish you all the best. And for all of you, some of you have been with us for all 43 sessions. I know the fatigue and the tired and the exhaustion and the fear is there, but let's hashtag refuse to fear. Let's stick with this. Let's do all the right things. Let's stay corona-free for as long as we all can. My family, thankfully, has been corona-free so far. I've got another 30 days probably until my turn is up to receive the vaccine at Mayo Clinic. 2020 has been said to be the year that should be forgotten and is the awful year. There's been a lot of special things that have happened in 2020 as well for all of us. And those who've experienced tragedy, it's an awful year, no way to sugarcoat it. But for those of us who haven't experienced awful and tragedy like that and sadness to that level, there's been a lot of special things. I've been home with my family more in 2020 than ever in the previous 20 years of my faculty life at Mayo Clinic. So I've been grateful for a lot of things. I've had more time with you all in 2020 than ever before in my years as president of the board of the SADS Foundation. And I'm thankful for each and every one of you and for the way you have stimulated us and inspired us and made us ask new questions in our research programs to gain new answers. So for all of you, I wish you the best. Here's a couple things I leave you with. So 2020 is an amazing year. Oh, will it come through? Not very well. Well, that was my granddaughter, sorry. And then last night was our anniversary, and that's my bride of 32 years. So 2020 is also an incredible year. Every year we get is a blessing. And so I just leave with all of you, for those in which a week from today is just a special holiday, well, happy holidays. And I hope you have a special one. But for many of you, like for my family and for myself, a week from today, December 25, is one of the most holy days of the year, Christmas, a time where our Savior is born and hope was brought into this fallen world. So for those who celebrate the fullness of Christmas, I wish each and every one of you a Merry Christmas. And this will be our final one of 2020. But guess what? I will get to wish you a Happy New Year on New Year's Day, January 1st, 2021. We're going to have a special program together celebrating New Year's resolutions. Bring your resolutions to our get-together. We'll share them together. And we are going to start on day one of the new year with SADS Facebook Live session number 44. And I can't wait to ring in the new year with all of you. Until then, have a Merry Christmas and have a wonderful remaining 13 days of 2020.